All right, so the final two aspects of my agenda are going to be about minerals and hemoglobin. Again, I apologize for the thing that happened with the voice, and I hope that you're hearing me well during the last part of the talk. So what is the effect of calcium and mortality in patients? Again, this was an observational study that looked at a large number of patients, over 10,000 PD patients, and they simply correlated their albumin-corrected calcium with adjusted all-cause mortality hazard ratio, all right? So again, the same pattern, a U-shaped phenomenon where the high all-cause mortality seemed to correlate it with a calcium that is more than 10.2, which is 2.6 millimoles per liter, or less than 8.5. So maybe we should try and keep our patients within this margin in order to optimize their outcomes. All right? This particular study also looked at the level of phosphate, and they have not demonstrated any higher mortality until the phosphate was really more than 6.4, which is more than 2.1 millimoles per liter, and this has been corroborated by other studies. Now, why do patients on dialysis and kidney failure retain phosphate? We know that, as the nephron mass drops, the functional capacity of the kidney drops, patients retain phosphate, all right? So again, the study that I've just mentioned, in addition to multiple other observational studies, have shown a higher mortality with a higher phosphate that is more than 6.5, which is 2.1 millimole per liter. And the hypothesis is that the high phosphate contributes to cardiovascular calcification and arterial stiffness. All right, and we also know that phosphate does contribute to secondary hyperparathyroidism in early CKD by decreasing the serum free calcium and by decreasing the hydroxylation of vitamin D. All right, so it does not just possible correlation with mortality, but also with bone disease. All right, so how should we treat hyperphosphatemia? Are there any strong arguments to decrease hyperphosphatemia? And the unfortunate answer is no. There is no clear evidence from clinical trials that lowering phosphate does result in in better outcomes. However, the KDIGO, based on just an observational study, have recommended pushing the phosphate down towards normal range. All right, and this is usually achieved by dietary phosphate intake. You should spend time counseling your patients about food and how to minimize phosphorus intake in food. We use oral phosphate binders all the time, but again, to your surprise, there isn't any good randomized controlled clinical trials that have shown, using phosphate binders does really improve the hard outcomes, which is death. All right, and we should always be taken in the context of the benefit and pill burden. All right, and we should also look into optimizing the peritoneal dialysis prescription because obviously more dialysis, earlier residual kidney function does clear phosphate better, and more dialysis results in more phosphate removal. Now, it would be very helpful to familiarize yourself with the phosphorus pyramid. All right. To my surprise, at least, I learned that a lot of processed food is purposefully and on purpose have inorganic phosphorus added to it with the goal of extending the shelf life and enhancing the flavor of that food. All right. So in processing the food, they do add inorganic phosphorus, and inorganic phosphorus is very well easily absorbed in the gut and results in high phosphate in these patients. So really, our patients should really get good counseling on how to try and avoid processed food, especially soft drinks like cola, dehydrated milk, processed cheese, nuggets, things like that. All right. Egg yolk has a lot of phosphorus, nuts, So the more time you spend educating your patients, the more rewarding that is going to be. Obviously, phosphorus is present in high protein food. So you don't want to limit their protein intake in order to avoid malnutrition, but you want to have a good understanding about this and also about boiling and things that could potentially lower the phosphorus content in food. And all of that would be quite helpful if you are providing or you're aiming to provide high quality PD care. All right. Now, final slide probably, or final aspect of my talk is hemoglobin. And this was a study that looked at over 9,000 PD patients who are treated with an erythropoietin-stimulating agent and just simply correlated their level of hemoglobin with mortality. And as you can see, compared to patients who have less than 11 to 12, patients who had lower hemoglobin, less than 11 to 12, had higher, significantly increasing higher mortality than patients who had more than 11. All right. So what this suggests is that lower than 11 is not good, and higher than 11, in this particular study, there was no signal of adverse outcome up to 14. All right. So again, perhaps we should try and get their hemoglobin to 11 and higher in order to minimize their mortality risk, although this is an observational, just hypothesis generating study.